welcome everybody to this webinar that I'm hosting today. My name is Nina Bailey and I'm going to be talking to you today about our new Optio3 blood spot fatty acid biomarker test. Now this is a new service that we've recently launched, and the aim of this is not only to complement our EPA range of supplements, but also to help you as practitioners to identify your clients' individual three requirements and offer them a more bespoke method of dosing, because we do know that some of the key issues that are facing you as practitioners is understanding where fatty acid deficiency can play a role in your client's symptoms, when supplementing with omega-3 fatty acids can be a benefit, but predominantly how much omega-3 do you need to give to your clients to actually elicit an improvement in symptoms. And there can be huge individual variation in response to treatment with omega-3 fats, and increasing evidence to support a more tailored approach to dosing is based on this sort of individual's absolute omega-3 requirements rather than a sort of one-size-fits-all approach. So I'll kick off and just a little bit of background. Health consequences associated with low intake long chain omega-3 fats have become a central issue in the area of nutritional lipid research. And we know that low grade systemic inflammation is highly prevalent within the UK population, linked to omega-3 deficiencies, and it's a known risk factor for numerous health conditions. So anything through from neurodevelopmental disorders, mood disorders, cardiovascular health, autoimmune inflammatory conditions, and so on. Currently, our recommendations for intake are set at just under 500 milligrams a day. But there is evidence to suggest that in some cases we may need to take significantly more than this amount, and certainly evidence that omega-3 can reduce disease risk, and specifically evidence sort of focuses a lot around cardiovascular health, is certainly sufficiently strong to recommend in some cases that individuals take more than a gram a day. In certain cases, for example, for triglyceride management, you could end up needing to take anywhere between 2 to 4 grams a day. So much higher, basically, than the current recommendations that are sort of outlined to sort of keep everything ticking over, if you like. So there's this sort of idea that there is additional intake of long-chain omega-3 fatty acids that are beyond current recommendations, that may be needed to raise our omega-3 levels to predetermined levels that are defined as health protective. And so what do we actually mean by this? And one thing to sort of really sort of focus on really is that with some blood spot tests, companies will sort of give you a range of fatty acids. So you'll get your fatty acid results, and there will be a range that were considered to be sort of a normal range, and they will aim to sort of target those and increase individual levels. But because there are no sort of well-defined normal ranges that are sort of publicised really, we don't focus on those. In fact, we take the individual fatty acids and we relate them to published biomarkers. So biomarkers that are well established, that can serve as diagnostic or predictive biomarkers of poor health and disease risk. And the three ones that we really focus on are the omega-3 index, the omega-6 to omega-3 ratio, and the AA to EPA ratio. And these biomarkers play a really important role in our understanding of people's individual requirements. So what's really interesting about the omega-3 index and the AA to EPA ratio is that there is a direct correlation between the two. We aim really to have a higher omega-3 index, so 8% or higher, and I'll go into a little bit more about that in a moment. But if our omega-3 index is nice and healthy and a nice big number, then our AA to EPA ratio correlates by being small. So this is good. So we have a high omega-3 index and a low AA to EPA ratio, and this is a sort of biomarker of sort of optimal health, if you like. So it's health protective. So if we talk about omega-3, we know that they have a broad range of health promoting effects. They have actions on our genes, our genetic makeup, metabolism, and they're involved in multiple regulatory systems. And although these fatty acids actually have direct actions, the sort of area of real importance is the fact that they are precursors to bioactive metabolites that look after our cardiovascular system, our immune system, our inflammatory pathways. And in fact, it's the resolvins that play a direct role in sort of switching off the inflammatory response. And we know that failure to resolve inflammation increases our susceptibility to the development of chronic low-grade inflammatory-based diseases. So if we have a low intake of omega-3 in our diets and a low omega-3 levels within our cell membranes, then we are more likely to have levels of inflammation that could cause issues. If we increase our levels of omega-3, so increase our dietary intake, increase at the cellular level, then we will naturally reduce inflammation. And so this diagram really is to sort of show the relationship between omega-6 and omega-3. So we're talking about omega-3s being anti-inflammatory, but partly it focuses on the ratio of our intake of omega-6 to our ratio of omega-6 to omega-3. Now, omega-6 are predominantly pro-inflammatory, and omega-3 are considered to be anti-inflammatory. What we need to really remember is that the omega-6 family can give rise to both inflammatory and anti-inflammatory end products, but it's the pathway taken either through DGLA here or AA that is dependent on how much omega-3 there is in the diet. If we increase our intake of omega-3, then delta 5 desaturase converts ETA to EPA. So we get an increase in anti-inflammatory products. If our omega-3 level is low, then delta 5 desaturase prefers to convert DGLA into inflammatory arachidonic acid. So getting the balance right is really important. And for practitioners, understanding the sort of concept of the omega-6 to omega-3 ratio is very well defined, but it's actually the ratio directly of arachidonic acid and EPA that really tell us what's going on in regards to inflammation within the body. So it's the increase in anti-inflammatory metabolites that are derived from EPA. They lower the more pro-inflammatory metabolites derived from omega-6 arachidonic acid. So EPA not only gives rise to anti-inflammatory products, but it blocks the production of pro-inflammatory products that are derived from arachidonic acid. And it's this role in regulating inflammation that is at least partially explains the health benefits that are attributed to omega-3 through fish consumption or directly from fish oils. And these anti-inflammatory actions of omega-3 are very well defined when we look at in vitro and animal experiments. But the outcomes are very, very positive generally in these, and we kind of get to understand a lot of the mechanisms that are involved. But we have a huge amount of control in the design of these studies. So whilst the outcomes of these type of studies is generally positive, what we find is that when we look at trials of marine omega-3 fatty acids in patients, the outcomes can be quite inconsistent and quite confusing at times. And the conflicting results are likely due to be in part through differences in study design, sample sizes, the type of samples that are studied, background diet, omega-3 supplement choice. Again, there there are huge amounts of omega-3s that are on the market, and consequently a lot of different types of omega-3 actually used within studies themselves, anything through from sort of cod liver oil through to high concentrated EPA, for example. So you're going to get really different outcomes from those. Study length, but predominantly, and this is the sort of part of the focus of this talk today, is that an individual's baseline levels of omega-3 can actually have a profound effect on the outcomes of an omega-3 intervention. And in fact, one of the most prominent outcomes in studies are observed in those individuals who have the lowest omega-3 levels and predominantly the lowest levels of EPA. So basically what this means is that if you're treating a population or within a study and you're treating them for depression, for example, using EPA, individuals with the lowest amounts of omega-3 within their cell membranes will respond more significantly than individuals who, I guess if you want to call it deficiency, those with the highest levels are less likely, or you're less likely to see sort of clinical outcomes there. So addressing baseline levels is really important when we're looking at treating individuals with omega-3 acids. And interestingly, in spite of the importance of omega-3 fatty acids, very few studies generally monitor the correlation between supplement intake and the actual enrichment of these fatty acids in red blood cell membranes and plasma. And we know that if we measure EPA and DHA within blood, for example, we can use it to sort of look for deficiencies through suboptimal intake, for example, of omega-3 fatty acids. And the biomarkers, as I've stated, that we use for personalizing omega-3 fatty acid dosing are the omega-3 index, omega-6 to omega-3 ratio, and the AA to EPA ratio. And the omega-3 index has been around for a long time. We're very familiar with this, and it was originally developed as an informative risk factor for the development of cardiovascular disease. It's defined as the content of EPA and DHA within our cell membranes, and it's expressed as a weight percentage of the total fatty acids, and it reflects tissue fatty acid composition as well. Huge amounts of data from epidemiological and dietary intervention studies have shown us that the desirable target value for the omega-3 index is 8% or more. Some studies even go on to suggest that 10% should be our sort of ideal fix. Individuals with an omega-3 index of less than 4 are sort of recognized, or this is recognized as undesirable. And we actually know that a low omega-3 index, so 4-ish, thereabouts, is associated with numerous health conditions, including neurodevelopmental and mental health disorders and cardiovascular disease and so on. And there's a huge amount of interest at the moment in the use of the omega-3 index actually as a biomarker of mental health. And anybody who's sort of eating a classic Western style diet, if you like, is likely to have an omega-3 index of around 4%, anywhere between 4% and 8%, sometimes lower. To get your omega-3 index up to 8%, you have to be consuming very low levels, or much, you have to moderate, I guess, your intake of omega-6 and increase your intake of omega-3, so oily fish, preformed through supplements as well, for example. And the validation of the omega-3 index is enormously strong. And this is just to sort of verify this, really. This is probably one of the most cited of the sort of graphs, if you like, taken from the Physicians' Health Study by a group led by Albert in 2002. And they showed that if you increase your omega-3 index, so for example, in the red bar we can see 3.58. If you increase your omega-3 index up to 6.87, you reduce your risk of sudden cardiac death quite significantly. In fact, there's a 90% reduced risk of sudden death amongst those men with levels of EPA and DHA as defined by the omega-3 index in the highest quartile compared compared to those in the lowest quartile. So it's quite a strong sort of message about sort of increasing our omega-3s. And we know that the the omega-3 index is well recognized to lower the risk of cardiovascular disease. And a number of studies have shown that incorporating omega-3s into red blood cell membrane increases in a dose-dependent manner. So this is a study from 2004 showing that as you increase your intake of omega-3s, so we've got time zero, so we've got 0 grams starting omega-3 index of 4.7. After 12 weeks, with 500 milligrams of omega-3, you can raise it to 7.9. After 12 weeks at 1 gram, 9.9, and then 2 grams, 11.6. This is quite an exceptional study. I must admit, I haven't been able to find any other studies that have conducted a dose response that actually gets the omega-3 index up to that kind of level. So it's quite unusual. But generally, omega-3 index can be raised in a dose-dependent manner. This is a more sort of reflective study published in 2013. And the relevance of putting this graph in, or this table in, like, is really to show that there is a huge variability between individuals. So we've got our change in omega-3 index here after dosing with either 300 milligrams, 600 milligrams, 900 milligrams, or 1,800 milligrams of omega-3 per day. And this is over a period of 5 months. So whilst we can see that there's a nice dose response, but individual variation in change of omega-3 index is quite staggering, really. And in fact, excuse me a minute. Sorry. In fact, the biggest variability was influenced by the original baseline omega-3 index coupled with body weight. And these were the greatest influencers when looking at changes in omega-3. So you can take two individuals, you can give them exactly the same amount of omega-3, but depending on what their baseline levels are and how much they actually weigh in kilograms, for example, will directly influence their change in omega-3, so their improvements in omega-3 index. So we know that incorporation is in a dose-dependent manner. We know that individuals with the lowest omega-3 index have the highest increase, so they respond more favorably than individuals with higher omega-3 indexes, for example. Individuals with high baseline omega-3 index show lower omega-3 response to treatment. So as our omega-3 index increases, it actually begins to slow down. So we do actually sort of reach a state of saturation. So basically, the individuals who have the lowest levels will respond the quickest. So their levels will increase pretty swiftly and then start to slow down. And when it comes to stopping, if you stop taking omega-3 supplements, generally your EPA levels will return to baseline within a few weeks of stopping, whereas the washout period associated with DHA is much longer. And so this really supports the theory that EPA turnover and requirements are actually much higher than that of DHA, which is primarily it's a structural fatty acid, whereas EPA is your physiological omega-3, if you like. So its role in inflammation and cardiovascular health are more predominant than DHA in some cases. So raising omega-3 index, whilst the recommendations are around about just under half a gram, we know that despite the sort of recommendations to eat at least 2 portions of fish a week, the majority of the UK population doesn't really consume enough fish, especially oily fish. And certainly in some cases, the amount needed to achieve an omega-3 index that is considered to be health protective, so thinking about 8 to 10% is health protective, our intake is likely to be much higher. And again, higher initial doses may be required to affect a really rapid change in individuals with very low initial omega-3 values. And it was estimated by Flocketel in 2013 that the average healthy adult, and I think they were estimating around 70 kilos, this is sort of healthy adult, so no major um, sort of health issues there. With a low omega-3 index of around 4% would require at least 1 gram a day of long-chain omega-3s for at least 5 months to achieve an omega-3 index of 8%. Um, so that's quite sort of profound when thinking about intake. So if we actually start to look at some of the variables, and if we start to account for individual differences such as body weight, we can start looking at how we can improve precision for omega-3 recommendations, because quite often practitioners will say, or they'll see a variety of clients. These people will come into the clinics, they'll be suffering from a variety of different health conditions, and they all respond very differently. And we know now that body weight explains a high level of this the variability in omega-3 index and how we respond. We know that those individuals with lower versus higher body weight tend to have a greater response to a set dose of omega-3. So if you've got a 70 kilo person and a 50 kilo person, you give them the same amount, they're going to respond differently. So our omega-3 recommendations to actually achieve a target omega-3 index may most appropriately be made on the basis of body weight, and this could actually be looked at as similar to the current recommendations for dietary protein intake, for example. So we're talking about the omega-3 index, but we're also sort of talking about inflammation as well. And we know that Western diet, our lifestyle factors as well, especially those that create an inflammatory environment, contribute significantly to inflammatory-related disorders. We know that diets that are high in omega-6 tend to increase risk, and diets that are rich in long-chain omega-3 can reduce risk. But whilst we've mentioned the omega-6 to omega-3 ratio, we know that specifically it's the AA to EPA ratio and low EPA that appears to be associated with many inflammatory conditions. And we can simply modify the diet to reduce inflammation by manipulating the AA to EPA ratio. And there's also this strong correlation between the omega-3 index, the omega-6 to omega-3 ratio, and the AA to EPA ratio. So as I said previously, if we increase our omega-3 index by increasing omega-3 intake, we will reduce our AA to EPA ratio. So omega-6 to omega-3 ratio is well documented, but it's the ratio of AA to EPA that is actually an accurate indicator of inflammatory status. And if we increase our EPA intake, for example, what we see is a reduced production of pro-inflammatory products derived from arachidonic acid. We get changes in fatty acid cell composition of our cell membranes. So we change our membrane structure, we change the products that are involved in immune function and the inflammatory cascade. We see changes in cell signaling, we see changes in gene expression and cell cycle control, so proliferation, differentiation, and so on. And so it's shifting this balance between AA and EPA that is known to have quite significant sort of benefits to health. And this is a graph really to just show very quickly this strong correlation between the AA to EPA ratio. Here we have AA to EPA ratio and omega-3 index, omega-6 to omega-3 ratio and omega-3 index. And so yes, so if you have a high omega-3 index, your omega-6 to omega-3 ratio will be low. And again, our graph showing the relationship between the omega-6 to omega-3 ratio. When it comes to actually looking directly at healthy individuals, and I guess if we sort of talk about individuals who have been diagnosed with a health condition, the omega-6 to omega-3 ratio is significantly higher in patients compared to health comparisons. And we know that the fatty acid content of red blood cells can serve as a diagnostic or predictive biomarker. Increasing research is focusing on lipid changes, certainly within the relationship between the duration and progression of the condition. So the AA to EPA ratio, for example, is being looked at as a biomarker of cancer progression. And so this is where our OPTIO3 biomarker test really kind of fits in. We use the model that was developed by Flock and colleagues in 2013, and we estimate the dose, milligrams per kilograms a day, that is required to raise the omega-3 index to a desirable level, so anywhere between 8 and 10%. And we can do this if we know an individual's baseline omega-3 level. And in fact, the OPTIO3 is currently the only biomarker test that is available at the moment that offers such a bespoke dosing guide, and this is to optimize omega-3 fatty acid biomarkers for optimal health. And we recommend that individuals retest after 6 months. So the test, as I've said, it focuses on the omega-3 index, omega-6 to omega-3 ratio, and the AA to EPA ratio. And it comes up with a personalized plan that aims to achieve an omega-3 index sort of targeting around 10%. And this will reduce your omega-6 to omega-3 ratio down to around between 3 and 4, and providing a nice healthy AA to EPA ratio between 1.5 and 3. So let's have a look and see what you get with your test. So this is our test kit. So it arrives in a nice little box that will fit the letterbox. You will receive blood spot test instructions, and there will also be a personal information sheet. So that will give, or you provide, or the client will provide details on their sort of personal history. We need to know body weight. We need to know a little bit about sort of background diet. So, you know, do they consume fish? Are they taking any fish or supplements and so on? And this gives us an idea of sort of where levels are going to be at. And also any conditions, health conditions and symptoms can also be quite useful to know. Then within the kit, we get a spot saver card, disposable lancet, which is a small finger pricking device, a resealable plastic bag with a moisture absorbent bag within that, a little alcohol cleansing pad, and you get a return envelope. So you write your name and date on the day that you do the test. Now it's just important really to sort of clarify that we advise fasting overnight, and the best day to do it is on a Monday morning, so that you can ship the test back to us and we can get it to the lab within a few days, so that the turnaround is kept as short as possible. So another thing, this is our lancet. As you can see on the lancet at the top, there's 3 little grooves here, and this basically dictates how deep the needle will go. So if your client knows that they sort of have difficulty in bleeding, for example, then you can turn it around so that the needle goes a little bit deeper. It's a single-use only needle, so that it's really important that individuals read through all the instructions very carefully, making sure that they're really familiar with all the requirements of the collection process. And then the end bit is a twist and pull, and then you just flick the little button here at the end, pressing down onto the finger of choice after you've swabbed it down and cleaned your hands and that kind of thing. Now, whilst there are 5 circles here. It's important that one is filled. We only need one, but it has to be completely covering the circle there. So name, address, sorry, name and date, and then pop it back into the little bag, silica gel, pop it back into the envelope. Don't forget to put the personal information form back in there as well. Send it off to us, and then within around 7 to 10 days, we'll be able to provide the results. For anybody who wants full output of an example of an actual report itself, then please contact us and we'll send you one directly. But for now, this is just a sort of a brief summary, really. So, as I said, we concentrate on 3 areas. We look at the omega-3 index, omega-6 to omega-3 ratio, and the AA to EPA ratio. You will get a breakdown of individual fatty acids, total saturated and total mono, and so on. But these are the 3 areas that we really concentrate on. So, just for an example, this individual has an omega-3 index of just over 4. So this is sort of fitting just over the undesirable into the desirable, but very low still. Omega-6 to omega-3 ratio 6.9. Again, this sort of correlates with the low omega-3 index, and an AA to EPA ratio that is rather high as well there as well. So 7.38, which is coming into the sort of suboptimal, almost acceptable, but could well be reduced. And this individual reports a weight of 69 kilos, and so based on the model that we use, it calculates to actually raise a very low omega-3 index here of 4.73. To get that up to 10, you would need to take 1.6 grams of omega-3 EPA daily. And this would be over a period of 6 months. And then we'd recommend really that you retest just to see how things are going, compliance. Sometimes there may be sort of absorption issues and so on. So we do recommend performing the test certainly within 6 months, and then maybe yearly after that. Just a summary again of what we are analysing for here. And we have been asked about prices. So what's the price of the kit? The kit itself retails at £120. Practitioner trade rates are £65 plus VAT. And if you're one of our affiliated practitioners, your clients can use your affiliated practitioner code. That would get them 25% off, and you would then receive £25 commission on the remaining. We have a turnaround time of around about 7 to 10 days. We've launched this service pretty recently, so we're hoping to work on the turnaround time and get that reduced a bit. But for now, realistically, we're looking at about 7 to 10 working days. So really, to kind of summarise and to sort of clarify again a little bit about why practitioners would benefit, or why their clinics would benefit, and why your clients would benefit. We know that establishing omega-3 levels identifies those individuals with higher omega-3 requirements. So possibly, sort of, even if you haven't got any health conditions, then maybe if you're not eating fish regularly, then your omega-3 levels are going to be quite low. If you know baseline levels, it enables a bespoke dosing that aims to achieve biomarker status that is associated with the positive health, positive outcomes. One of the issues that practitioners really face is that they can often be restricted to the dosing guidelines that sort of relate to this sort of one-size-fits-all approach to treatment. So as I said, you will see a client, they're coming in, they're suffering from depression, for example, and everybody seems to get the same dose, and sometimes not everybody responds in the same way. So being able to offer a bespoke dosing guide will not only benefit your client, but it also add considerable value to you as a practitioner as well in providing the service. For those individuals who reach their targets, we then advise a minimum sort of maintenance dose of about 500 milligrams a day, and this is sort of in keeping with the government recommendations as well. And again, recommendations should be set to retest after 6 months, really just to sort of monitor outcomes. So if anybody would like some more information about Optio 3, you can go onto our website and have a look at the information on there. If you'd like a copy of a full set of results, then please email us as well and we can send you one out. Otherwise, thank you very much for listening. If you have any other questions, please feel free to get in touch. Thank you and bye.